Mm. Thank you. All right. Do you want to run through it? For
Yeah, the audio plays. There's a slide. It's I think the fourth one down, fifth one down. Yeah.
It's beautiful. Oh, I feel good.
We don't know what our
folks
are going to do next. But you can throw this down.
What is this a clip from? Oh, the Ryan White story. Okay, I see now. I was like, it looks 80s. All right. Are you doing this introduction, Mary? Oh, okay, great. So we have your introduction slide here. We just added it to your presentation so that Mary can have this up while she introduces you, and then it'll just go right into your presentation. Let me go ahead and screen share on the Zoom so that it will.
Okay.
All right. So it's already recording. Is this view okay with you? The one where you could see the next slide coming up?
Oh yeah. Yeah. There. Thank you. Yes. And then just keypad.
Or the arrows? Yeah. Or I think the keypad works too. So either way.
Okay.
All right.
Perfect.
Thank you.
Thank you.
I can tell you do. There are some. Okay. Thank you. What's on there?
Morning. Hi, Christy.
Thanks for being here.
It's great to be here. Thank you.
Awesome.
Thank you very much.
So, do you all refer to ART as art or ART?
ART.
Okay. I want to say it.
Morning.
It's chilly, and I just, it's chilly. I mentioned it to, you did, I did. He said, it's not. Yeah.
Yeah, but the sound's not set up.
Hey Renee, they're still setting up the sound, so you can just leave the other.
You plug that into your phone. Plug this into your headphones. Okay. It's the end, yeah. And what I'm gonna do is I'm gonna so if you could play something. Yeah.
Yeah, great, thank you. It's working. What's that? It's going through the speakers. Yes. All right, thank you.
Thank you everyone for your patience when we got the sound set up. So welcome to the De-stigmatizing STI testing and treatment for LGBTQA plus communities. Since 2021, the Reverend Dr. Bryce Thomas has served as the ART, antiretroviral therapy, clinical care manager for Music City Prep Clinic in Nashville. He navigates and manages the needs of ART patients in the clinic and works to expand clinical and non-clinical resources and support services for all of MCPC's patients. Additionally, Bryce is adjunct faculty for several theological schools and an ordained clergy in the United Church of Christ denomination with training in clinical pastoral education, gay couple counseling, conflict resolution, mediation, addiction recovery, and compassion fatigue. He's a certified peer recovery specialist, expanding support systems for patients struggling with addiction, mental health, and comorbidities affecting overall health and wellness. Please help me welcome Bryce. Thank you so much for being here.
Hey, thank you so much. It's great to be here. And I just want to say, can we give a hand to our IT people? I didn't get your name, sir, but I sure appreciate you know, make friends with your IT people at work, right? Make friends with them. They are your best friends. So it's great to be here. I'm excited to present some of my findings and research while working with Music City Prep Clinic over the last year. I've been there about a year, and it's been my first stint into full-time healthcare. I do have training in CPE and worked in hospice environments for that. But to transition from ministry in the pulpit into the clinic has been a really exciting evolution for me. And I feel like, if you will allow me, I'd like to bring in some of my perspective, not just from my work in the clinic, but also my work in ministry, because I know many of us come from religious affiliated organizations, and many of us have a faith experience that we bring into the workplace. And so I always take the opportunity to think through some of the theological perspectives that I've had training in, I've had experience, and how can I bring those into the clinic environment in a non-judgmental secular space. And so I appreciate you allowing me to share some of that. So founded in 2017, the Rod Bragg Music City Prep Clinic is a sexual and wellness clinic. You see, our mission is to get to 0 HIV transmissions in Nashville and Middle Tennessee. Who thinks that is an attainable goal? It's a lofty goal. However, it is a goal that we are committed to. Now, we work toward that goal by providing free PrEP and PEP prescriptions, regardless of the income or insurance status of our patients. So our services include a discreet, no-cost lab testing for HIV and bacterial STIs, plus hepatitis A, B, and C testing. Now, sexually transmitted infections, which is what we now call them instead of STDs, they are obviously a significant health issue for Tennessee adults, but particularly our young adults. 1 out of every 5 people in the US is estimated to have an STI, 1 out of every 5. And Tennessee's chlamydia and gonorrhea rates have been steadily increasing since 2014. While disparities in the prevalence of STIs among all age groups actually range from the demographics to the sexual health education accessibility, sexual orientation is a significant contributing factor. The truth is that gay and bisexual men are more likely to have unprotected sex than their cisgendered counterparts. However, it is the stigma of sexual orientation and sexual practices that has led to a stigmatization that inhibits a regular sexual health screening and use of prophylaxis, such as PrEP. And so the session has 3 main objectives: to, number 1, learn the disparities and barriers to STI testing and treatment for the LGBTQA plus community. 2, to identify the stigmatizing elements and barriers in your own setting. And then 3, to discover the power of what we call dual discussion protocols. And also encourage you to begin writing an individualized stigma-free interview process. Because who doesn't like to be stigma-free? Amen? Amen. So, part 1. Disparities and barriers to STI testing and treatment in the LGBTQA plus community. I really would like to introduce this section and share a video clip that kind of helps bring to bear a real understanding of those early challenges in the discovery of HIV infections. Brian White was 13 when he was diagnosed with AIDS. He was infected through a blood transfusion in December of 1984. Living in Kokomo, Indiana, doctors gave Ryan about 6 months to live. And when he returned to school, he faced AIDS-related discrimination in his Indiana community. But along with his mother, Jeannie White Ginder, he rallied for his right to attend his school. And then he gained national attention and became the face of public education about the disease. Surprising even his doctors, Ryan lived 5 years longer than expected. He died in April 1990, 1 month before his high school graduation. And in 1990, Congress passed the Ryan White Comprehensive AIDS Resource Emergency Act, known as CARES. Now, because of Ryan White's story and his activism, he's kind of been considered this poster child for HIV/AIDS epidemic. However, Doctors George Ayala and Andrew Spildner published in the American Journal of Public Health in July of 2021 that HIV is a story that is first written on the bodies of gay and bisexual men. They write that in 1980, Ken Horn, who was a gay sex worker in San Francisco, California, became the first person actually to be diagnosed with acquired immune deficiency syndrome, also known as AIDS, in the US. A year later, the CDC reported 5 cases of pneumocystis pneumonia among young homosexual men living in Los Angeles. And by 1982, the term gay-related immune deficiency gained traction in the media and among healthcare professionals to describe this assumed inherent link between homosexuality and what would later be known as the human immunodeficiency virus, or HIV. This term, gay-related immune deficiency, reflected the ignorance, the homophobia, the lack of diverse epidemiologic evidence that existed at that time. The statistics were horrific. For between 1981 and 2000, the first 2 decades of the disease, over 750,000 persons were diagnosed with AIDS. Nearly 60% of those died. 448,000 people. This high death rate in the early epidemic was concentrated largely among 4 intersecting groups: transgendered people, sex workers, people who use drugs, and gay and bisexual men. Now, while the outlook of HIV and AIDS seemed bleak in those early years of the epidemic, it has been the impact of biomedical solutions and antiretroviral therapies over the next 2 decades that changed the dynamic of the disease's prevention and treatment, specifically in the LGBTQA+ communities. But there has been a resurgence of infection in the last 10 years. You see, globally from 2010 to 2019, HIV diagnoses increased by 25% among gay and bisexual men, even as infections in other groups were declining. In the US, gay and bisexual men make up nearly 70% of all new HIV diagnoses each year. This is actually a chart that shows our patient population at MCPC, but it does closely mirror the national statistics. Shockingly, though, among those 70%, 31% are Black and 25% are Latinx. These numbers match very closely our clinic experience. However, we do understand that often patients are reticent to reveal their ethnic identity at first contact. And while the epidemiologic evidence continues to tell a story that centers the HIV pandemic on gay and bisexual men, it is public health agencies continue to cast their HIV response broadly to a general population. And so strategies for education and outreach in the US often presumes that access to care is consistent along the mainstream population. This message and this medium is geared toward the heterosexual, cisgender, able-bodied, socioeconomically secure, and here in the global north, to the white patient. And as a result, HIV services are rendered really difficult to safely access for those that are in need and most marginalized. But that was then, right? Unfortunately, in the last several years, we have seen economic disenfranchisement, racism, gender inequality, and homophobia codified in our laws and our policies, which is further limiting the provision and expansion of HIV services. Even now, in 2022, same-sex sexual behavior is criminalized in 68 countries. 89 countries have laws that specifically criminalize HIV transmission, exposure, or non-disclosure. And within the US, 30 states still criminalize people living with HIV. And these laws are disproportionately affect economically poor, Black and brown, and gay people. Such laws encourage violence, discrimination, and stigma, which worsen health disparities among gay and bisexual men. After 40 years, not only do power inequities and HIV disparities remain, but they have deepened, particularly for gay and bisexual men of color. And it's not surprising then that these discriminatory practices and policies actually inhibit the care of these at-risk populations. In 2016, the CDC reported that 1 out of every 2 Black men who have sex with men will be diagnosed with HIV at some point in their life, if these diagnosis rates remain the same. For Hispanic men who have sex with other men, the ratio is 1 out of every 4. And for white men who have sex with other men, the ratio increases to 1 out of every 11. Now, a common thread that kind of runs through some of these human rights concerns described here is this lack of respect for and a protection of bodily autonomy and integrity. Bodily autonomy and integrity are sacrosanct for human rights. This means that all people, including gay and bisexual men, have agency and autonomy over their own bodies. It also means that all people have the right to be self-determining, to be secure from violence, including sexual assault, and have opportunities for sexual satisfaction, pleasure, and reproductive choice. Public health responses to the HIV and overall health needs of gay and bisexual men are too often designed and enacted solely with a disease containment focus and without a serious consideration for the fundamental rights of humans. Research studies have reported that stigma has been a key obstacle for individuals living with the HIV and AIDS, and is also a major barrier for HIV prevention. Gay and bisexual men living with HIV and AIDS are likely to experience both HIV stigma and gay-related stigma, which may cause significant psychological stress. And such stigma may also be influenced by this individual, the patient's own perceptions. And sometimes that gay and bisexual men who contract the disease are somehow to blame for their own actions. For example, a report of the CDC in 2000 found that people who were most knowledgeable and educated about HIV infection were least likely to believe that people with HIV and AIDS got what they deserved. And some studies have also shown that individuals are more likely to place blame and anger on the LGBTQA plus persons than they are on other populations with HIV. Given these findings, the gay and lesbian and bisexual people living with HIV and AIDS are more likely to possess symptoms of depression and engage in risky healthy behaviors. It is so important for counselors, clinicians to demonstrate cultural competence when working with this population. So I mentioned I'm ordained in the United Church of Christ. This is my 18th year in ministry. And for me, I'm always amazed how the experiences, the stories, the parables in the Gospels continue to bring new light and meaning to my own life and to my work. And so I hope, if you will, you allow me to share with you a story that many of you, I'm sure, are aware of. But I'd like us to hear this story, perhaps, from a little different perspective. From the Gospel of Luke. So Jesus replied, a man was going down from Jerusalem to Jericho when he fell into the hands of robbers. They stripped him of his clothes, beat him, leaving him half dead. A priest happened to be going down the same road. When he saw the man, he passed by on the other side. So too a Levite, when he came to the place and saw him, he passed by on the other side. But a Samaritan, as he traveled, came to where the man was, and when he saw him, he took pity on him. He went to him and bandaged his wounds, pouring on oil and wine. Then he put this man on his own donkey, took him to an inn, and took care of him. The next day, he pulled out 2 silver coins and gave them to the innkeeper. Look after him, he said, and when I return, I will reimburse you for any extra expense that you might have. Now, which of these 3 do you think was a neighbor to the man who fell into the hands of the robber? So Jesus's question, the answer is pretty obvious, right? Many of us have grown up, whether we come from a religious experience, Christocentric in focus or not, this understanding of a good Samaritan and what is that trait, that unique experience. But Jesus was teaching more than just kind of a lesson in social responsibility. So I want to dig into the context a little bit, if you will. You see, Jesus is answering a question that a lawyer had just asked him. What must I do to inherit eternal life? The man who's questioning was a religious lawyer. He prided himself in his understanding of all 613 points of the Torah, also known as the Leviticus Code in the Old Testament. The religious leaders of Jesus's day had inherited this system that had turned obedience to God into some kind of moral obstacle course. It was so strewn with picky do's and don'ts that it left the average person on a permanent guilt trip. This approach contradicted what Jesus taught, and confrontation became inevitable. So the lawyers, along with all the other religious leaders, were constantly trying to discredit this perspective. So Jesus asked the expert first, what is written in the law? How do you read it? And the lawyer responds, love the Lord your God with all your heart, with all your soul, with all your strength, with all your mind, and love your neighbor as yourself. Jesus responds, you've answered correctly. Do this and you will live. It was a good answer as far as it went. But you know what lawyers can be like. They're looking for the loopholes, if you will, and sometimes the law, looking into the exposed cracks that might be corrected. So this lawyer responds, who is my neighbor? And that's when Jesus shares this parable. See, Jesus is setting this story on a road from Jerusalem to Jericho. It's a distance of about 17 miles. Jerusalem is where the temple was, and it was the center of religious life. The priests were the highest class. The Levites were the lower level of servants doing tasks like working in the temple, keeping the altar going, lighting incense, singing. And when they weren't on duty, they lived in Jericho. And so they would travel the road between Jerusalem and Jericho. Now, travel in that day was very hazardous. One stretch of the road was known as Way of Blood because so many people were robbed and killed there. This was where Jesus set the scene for his parable. So people knew exactly what he was talking about. But in Jesus's story, the first person to see the victim is a priest, but rather than get involved, he passes on to the other side. He's followed by a Levite, a temple worker. The Levite does the same. He passes along by. And then comes this Samaritan. A what? A Samaritan? Now, Jesus would have caused quite a stir with that, because Samaritans were a mix of Jew and Gentile. And in ancient Palestine, they were not well liked by members of either society. They were called half-breeds, heathen dogs, and considered them to be spiritually defiled. But in Jesus's story, it's this outcast who stops to help. And not only does a Samaritan help, but he goes far beyond what any other person would do. He cleans their wounds with oil and wine to disinfect, bandages them. Now, people didn't carry around first aid kits, right? In ancient Palestine. He would have likely had to tear up pieces of his clothing, making bandages. And then he puts the injured man on his own donkey. It takes him to an inn. He gives the silver coins to the innkeeper, promising to reimburse. This is an exceptional level of hospitality, especially for a total stranger and someone who is supposed to be a social enemy. But this Samaritan did not let those differences stand in the way. With this deceptively simple story, Jesus confronts the lawyer and asks him, which one of these do you think was a neighbor to the man who fell into the hands of robbers? See, Jesus is turning the question around. He's not asking which people should you help. He's saying to answer that question, you need to put yourself into the shoes of the man who was beaten and left to die. So the better question is, when I need help, who do I want to help me? Don't you hope the Samaritan will be your neighbor? Who is a good neighbor? The answer is obvious. The one who had mercy on him. And Jesus delivers this knockout punch. Go and do likewise. I tell this story because for me, I center everything that I do in my experience of what it means to serve other people. And regardless of my sort of understanding of their behavior, whether to judge it, whether not to judge it, whether to consider what they've done to themselves is their own reward, I know that for me, the only way I can do this work is to know that I don't have the power within me to do it myself. But what do I have? I have a connection to something higher and greater than me. Whether you call that your higher power, your God of choice, or an experience of the divine that you and only you can name. We need to put ourselves in the place of that man who was beaten and left to die. We are that man, because he represents all of us, all of humanity, because we all need healing and wholeness. We're the ones that the Good Samaritan can save from our own self-destructive attitudes and behaviors. The Good Samaritan is the only one who can help us. The Good Samaritan is our gift of healing and restoration, our need for a higher power that heals us. It's the only power that can, and we all are in desperate need of healing. Here's the bottom line. When we heal others, we are healed ourselves. Can I hear an amen if you believe that? So that leads me into this understanding of what is it that we do that is our version of the Good Samaritan. And we call this the MCPC experience. The MCPC experience means world-class, affordable healthcare and wellness with attention to earning every patient's trust through safety and courtesy, showcraft, and efficiency. Patients come to us for STI prevention and treatment and leave healthier, more confident, and better informed than when they arrived. Our mission is to end the HIV epidemic in Nashville, and our philosophy of service is to help others embrace sex without fear and love without stigma. I'd just like to show a quick summary of that philosophy of service. So how do we get there? Our mission to get to 0 new HIV transmissions in Nashville, Middle Tennessee. And we accomplish this mission with really one purpose in mind. We foster sex esteem. Sex esteem equals self-respect, self-love. We believe a healthy sex esteem is the first step to developing a healthy sex behavior. We take responsibility for protecting ourselves. We take responsibility for shielding others from STIs. This means that we want our patients to feel good about who they are as sexual beings. We understand that sex is a normal and healthy aspect of being human. And our stigma-free sex approach to healthcare helps our patients express themselves authentically while minimizing or eliminating their risk of an STI. This is how we build trust and will end HIV. We don't believe there's any benefit to shame or regret, but that our patients should enjoy their sexuality while staying healthy and safe and make choices that encourage both. MCPC serves everyone regardless of gender identity or sexual orientation, but most of our patients identify as part of the LGBTQ community. Many of our patients have been stigmatized for their cultural, ethnic, sexual, or gender identity. So we try to remove that stigma by providing a shame-free healthcare in a setting that is welcoming and professional. We emphasize the self-empowerment of taking responsibility for your own sexual health. And we encourage patients to protect themselves with PrEP instead of relinquishing responsibility for their sexual health to their sex partners. And we encourage our patients to embrace who they are, the sex that they enjoy, and the people that they love. This vision is sex without fear and love without stigma. Now, we know that sexually transmitted infections are a fact of life for those who are sexually active. STIs are like any other infection you contract from another person. The flu, a cold, mono, pink eye, these are all examples of infections you can catch from sexual interaction with another person. But we generally don't think of a cold as something to be embarrassed about or have shame around. But this kind of shame when it relates to sexually transmitted infections is something that is built into our American culture. It's often a deterrent to people taking care of their sexual health. So MCPC creates a shame-free sexual health clinic by fostering healthy sex esteem and supporting our patients in having more satisfying, fulfilling, and healthy sexual experiences. Because we envision a world where fear and anxiety are no longer a part of sexual experience. We envision a world where you can be yourself and others respect you for doing so. A world where you can embrace the sex that you enjoy and the people that you love. It's this mission, purpose, and vision that we call the MCPC experience. So how do you get there? How do you address and eliminate stigma? And so I'd like to present to you in the last 15 minutes of the presentation what we call a dual discussion protocol. Now, the power of this kind of protocol is a strategy we use to develop cultural competency in regard to our patients. The philosophy behind this stigma-free interview process is centered in these 3 areas: knowledge, empathy, and diversity of identity. So when we develop cultural competency with this population, we understand that our clinicians should reflect on how their own attitudes and beliefs about gay and bisexual men may be developed at first, as well as their own biases or stereotypes about people living with HIV and AIDS. So this introspective process begins by thoroughly examining our own cultural heritage, how our own race, our ethnicity, our gender, our sexual orientation, our religion or our spirituality has influenced that worldview. For example, a clinician with a strong Christian identity may not recognize her biases about same-sex relationships and may inadvertently display a judgmental facial expression, which could damage that rapport with an LGBT client. It is expected that culturally aware clinicians should recognize their limitations, which in turn will encourage seeking out educational experiences to address those biases. And so knowledge of HIV and AIDS in the LGBTQ community is a step toward building that cultural competence. Statistically, gay and bisexual men make up about 65% of our total client base. However, they are not a monolithic group. They are quite diverse in terms of their life experience. And a potential microaggression, a subtle form of discrimination that might occur for an unaware clinician, is to provide services based on the assumption that all gay and bisexual men have a common experience, or that their sexual behavior is stereotypical, because gay and bisexual men are diverse among themselves. A culturally competent clinician would be well informed about issues involving HIV and AIDS, so that time in the counseling session can be spent on the patient's emotional experience, instead of constantly having to be educated about the virus. A gay client may drop out of therapy because he feels that the majority of time is spent on educating his counselor about HIV and AIDS instead of talking about their emotional experiences of it. That's what brought him to seek care in the first place. You know, good place to start. Take a picture of this or write it down if you like, but these are some really great antiretroviral therapy education programs. The Khan Academy is filled with videos and experiences of learning about just the complexities of the HIV virus and how they mutate and what are the experiences of antiretroviral therapy against it. The body.com, SEATCE, that's a mistake there. It's SEATCE.com, which is practice transformation. It involves a goal setting, workforce training, cultural change within an environment, quality improvement, outcomes measurement, and adapting organizational tools and process to support advances in models of team-based care. And these two national curriculum out of the University of Washington are also great opportunities for education. Cultural competent care providers may learn that the most effective approach or technique in working with the LGBTQA+ community parallels the most effective skills in working with any client. So when you use techniques like empathy, and I love the presentation yesterday by April about this understanding of empathy as a patient-facing, patient-based process. What is the patient feeling? What are they experiencing? Looking at it from that perspective. When we use techniques like empathy and unconditional positive regard, it's an essential way for clients who have their own internalized oppression, blame or guilt or shame as a result of their sexual orientation or HIV status. Empathy, unconditional positive regard, is an important part of self-actualization. It refers to the act of viewing another person as a human being possessing their own distinct agency, despite the flaws or destructive behavior that they may struggle with. They are always striving toward a place of self-actualization. I mean, aren't we all, right? We'll explore our use of this dual discussion protocol as an empathic tool at the very end of the presentation. And finally, counselors and clinicians must recognize that LGBTQA+ persons have multiple identities that must be accounted for. that might influence their everyday lives in numerous ways. People of color, transgendered people, those living with disabilities from diverse ethnicities, religious heritage, their age, their social class, all of these are arrays of social identities that may need to be integrated into the patient's treatment. For instance, a gay or bisexual African-American client may report experiencing discrimination and how it affects his mental health. And so in that case, a culturally competent counselor would be cognizant not just of exploring the client's HIV status or sexual orientation, but also examining their racial identity in order to provide a safe, non-judgmental space. Using techniques that address a client's intersectional identities may be vital in developing a strong therapeutic alliance, providing a safe place to clients. This dual discussion protocol addresses those identities, and it starts at the very beginning with our intake process. And so we have a series of questions that we ask our patients before they even see a provider. Answers to those are important for discerning protocols that will enable the providers during the exams to be grounded in a cultural competency. We'll run through a few of these areas of self-disclosed data. We inquire about sexual orientation early in the intake process. And in addition to collecting this for treatment purposes, as I've described earlier, it allows the patient to express their own identity. But labels are only as helpful if they adequately express the full range of somebody's identity, right? So we also allow patients to even decline that option or express uncertainty of how they actually define their own sexual identity. We even provide an opportunity for self-determination. You don't see it in the intake form? Well, then help us understand you. It's also important for us to honor patients' gender identity and express it in their terms. We have buttons that we all wear around the clinic. They're pronoun buttons. I'm sure you've seen this. This is a way of us sort of creating that environment of which I've been talking about, right? It allows someone to see a reflection of the person that they are engaging. And so we hand these out freely. And if you're interested in learning how to get access to some of these, believe me, our pharmacy partner, Avita, has millions of them, and we'll be happy to send you some. I've got cards here, and happy to be in touch with anyone. We collect someone's gender at birth as well. It gives our providers an insight necessary to approach any biological concerns during that exam portion of the appointment. The data collected in this medical history portion of the intake allows our providers to investigate concerns that might arise within that interview portion of their exam. Also, from our blood, urine, and specimen collection process. If you had an STI, don't be ashamed to tell us. It's gonna help us treat you. And an important part of our dual discussion protocol is allowing the patient to describe for themselves the reason for their visit. We understand there are two distinct possibilities for our patients. One, they've potentially been exposed to an STI, or two, they want to protect themselves from future exposure. And so it is our job to move them from the first to the second step. And with each encounter, our providers and our navigators consider the barriers and possibilities to transition every one of our patients into PrEP. Now, of this writing presentation, I checked the numbers. Our providers have seen 13,740 patients since our inception in 2018 in our Nashville clinic. And we are adding an additional 400 to 500 new patients every month. Out of our total patient population, 5,636 have been prescribed PrEP, and are continuing to come back. That's about 40% of our patient population. And while we are very proud of that number, we are not going to stop there because we still have many opportunities to continue this work. The way forward continues to be building trust with our patients. We understand that visiting an STI clinic can be stressful. No one gets excited about getting tested. We put it right out there. We know you might be a little fearful today. There's high levels of anxiety, fear, and frustration. We ask our patients what those concerns might be, and the answers enable us to do a better job and anticipate any blocks to their health and wellness. I don't have time, but I wanted to share a few comments, anonymous comments that we've received. We survey every one of our patients after they leave. We want to know about their experience. We want to know if there's ways that we can improve. And a couple of these I just think are very reticent of our experience. One patient said, "I'm very new to coming out. I need to do so because I'm in recovery for alcoholism. I'm 8 months sober and I'm doing everything to stay sober, even come to terms with my identity. But my main concern is that I have met this young, beautiful man, and for his protection and mine, I feel seeking help in this area is an absolute must. He is taking protection and I owe him the same." Sorry for my life story. We are good Samaritans. And not only are we good Samaritans, but we are the ones that have been beat up and left laying along the road. And when we engage our patients from that dual perspective, that I am just like you, and you are loved, and we're here to help, that's how we earn trust. Thanks, everybody. I appreciate your attention. Yeah, I'd love to, sure.
On utilizing behavioral health specialists within a medical or all setting, as it relates to kind of changing mindset. I was thinking of this because there's some recent things that have happened within my community of Jackson, Tennessee, with the Jackson Pride that was just recently. There's just a lot of media, negative media about it. And so I just kind of want to get your thoughts on kind of utilizing behavioral health specialists to kind of change the mindset.
Yeah, absolutely. I mean, we have a very strong presence in Nashville. We're at Pride. We're at second year at Williamson County, which is Franklin, Tennessee, which is probably one of the most conservative counties surrounding Nashville. We have a presence there. We've created our own block party, neighborhood block party around our new clinic that just opened this week, which, by the way, I also wanted to talk about a little bit about that environment. We have a restaurant, bar next to a community center with our clinic and our new 12 exam rooms and our pharmacy right there, all in the same complex. I didn't get a chance to see last night, but it sounds like that's a model that's working for a lot of clinics. But our understanding is you're not just coming to a clinic, you're coming to a community space. And so it's important for our clinicians also to have a perspective about what are some of the mental health barriers, right, toward that. We just hired a new clinical counselor, Maggie. She's here today. She provides our social work and access to resources. And then Stephen Ugoe, which is our community relations director, also sort of has deep dive into some of the communities that we may not have good perspectives about. We need to learn and understand what are those barriers. So always looking at it from that perspective is absolutely perfect, and a perfect way to see through the eyes of a patient, right? So thank you for that. Absolutely. Get out there in the community and be seen, for sure. Yes, sir.
I just want to share, I shared with Stephen yesterday, so on the gay and bisexual dating app, I saw Music City Trip on there, but I always thought it was fake. because the marketing looks so real. So you all are everywhere. But I do have one question. So the LGBT community now, since PrEP has been out there, they have stopped using contraceptives because PrEP. And that's the reason why I believe some STIs are on the rise, because everybody says, oh, I'm PrEP, so I don't need to wear condoms. But that's not the case. Where is the conversation around still protecting yourself while also taking?
Yeah, that's a great point. And we're very clear in the exam process. PrEP will protect you from HIV, but it will not protect you from chlamydia. All right. So unless you want to come in and get a shot that's going to hurt for about a week, be careful and wrap it up. Right. And so we are not afraid to address that as well. It's important to think through. This is not just about protecting yourself, it's protecting your partner. And we are seeing that rise. And so it is something that our clinicians are very aware of. And some of our marketing is changing now around that as well. Right. And so as we approach STI testing from that perspective, that message needs to clarify and get stronger. So thank you for bringing that up. Yes, sir.
So brief, actually, so obviously in the community, we have a lot of runaways, stuff like that, where parents, I mean, we all know people that their parents are kicked out because they're gay. How do you assist with that? Do you assist with community violence they experience, victim trafficking, or anything like that?
Well, our main goal is to connect to partnerships in Nashville. The Sexual Assault Center that we are continuing to deepen that relationship. I just met another clinic or a conference attendee today from the Ahmed Clinic Foundation. I got so excited about that because the needs of our immigrant and undocumented patients, and also those from Spanish-speaking countries, is something we need to get our heads around, because that is increasing. We're seeing a rise in that. So I think it's getting those partnerships, getting out into the community. Stephen is doing an amazing job about making those connections. We don't have to do everything, but there are people in our city doing everything. And so all we need to do is find, and that's what our goal is. Yeah.
And my thing was, how do you combat against accidents on sex education?
Well, I don't look at it as combating, but as providing alternative sort of experiences, right? We get a lot of get a lot of comments about, no one ever told me about sex. They didn't tell me about the dangers, they just told me not to have it, right? And so understanding that the more we can educate our patients, the more informed they will be about making those right choices the next time. It's not about combating what's out there, it's about providing our unique experience. And I think that that's what we try to do and set standards for. So I think we're out.
And don't forget to go get that QR code on the back of your program and let everybody know how fantastic this session was. And let's give Bryce a round of applause. And Bryce, here's a little trophy for you. Oh, thank you so much. Thank you. That was just wonderful. Yeah, great. So proud. Proud to have now
You were there.
you
were there in the beginning.
I was. It just continues to do such great things.
Yeah. Well, thank you.
So good. Great. I have the next one set up.
Hi, I'm getting you set up, Yoshe. How are you doing? Good.
Yeah, I'm gonna match you.
Actually, I'm gonna run to the rest. You have time.